Hello, and welcome to our presentation on Chiari Malformation. This will be presented by myself, Harper Bean, as well as Emily Bush, Eric Alberts, and Crystal Clark, who will all introduce themselves on the coming slides. This presentation is for NU 511 Advanced Physical Assessment, Pathophysiology, and Pharmacology as part of the MSN program at Mount Mercy University. Please enjoy.
My name is Emily Bush. I have been a nurse for about 15 years with experience in labor and delivery, OBGYN, women's health, and most recently in pediatrics as a school nurse for the past 4 years. I am pursuing my Master's of Science in Nursing degree with an emphasis in health advocacy. And this presentation actually has a special place in my heart because my son, who is now 5, was diagnosed with Chiari malformation and underwent the decompression surgery and the duroplasty that you're going to learn about when he was 3.5.
Hello, my name is Harper Bean, and I have been a nurse for the last 6 years on an inpatient cardiology and telemetry unit, where I currently serve as a nursing supervisor. At this time, I am pursuing my master's in the science of nursing with an emphasis in nursing administration at Mount Mercy University.
Hi, my name is Eric Alberts. I have been a pediatric nurse for the past 8.5 years. I have worked in various pediatric roles, including pediatric home health, pediatric medical surgical in the inpatient setting, and a little bit of NICU as well, neonatal ICU. I currently work as a pediatric emergency department nurse or pediatric ER nurse, whichever title you prefer to call it. And I also am currently a student at Mount Mercy University in the MSN program, or Master of Science in Nursing program, with an emphasis in nursing education.
Hi, my name is Crystal Clark, and I am an MSN student for Mount Mercy, and this is our presentation on Chiari malformation.
The objectives of this presentation are to provide an overview of neurology and the nervous system, including the anatomy of the brain and how it relates to Chiari malformation. We will also provide a comprehensive overview on the pathophysiology and physical assessment of Chiari malformation. We will explain the history, prevalence, and different types of Chiari malformation, as well as explore the management, treatment, and prevention strategies, including pharmacotherapy and surgical interventions. We will also define the most current and evidence-based practice for the management and treatment of Chiari malformation. To start, we will provide an overview of neurology and the nervous system. Neurology is the study of the nervous system, which includes the brain, spinal cord, and nerves. The nervous system is the command center of the body. It is comprised of 2 main parts, including the central nervous system, or CNS, and the peripheral nervous system, or the PNS. The CNS is made up of the brain and the spinal cord, and the PNS is made up of a network of nerves. Chiari malformation is a structural defect of the cerebellum within the brain, which is part of the CNS. For that reason, we will focus primarily on the anatomy and the physiology of the CNS as we move forward throughout this presentation. We will now take a closer look at the anatomy of the central nervous system. The central nervous system is comprised of the brain and spinal cord. The brain is an organ composed of the nervous tissue that is responsible for movement, senses, emotions, language, communication, thinking, and memory. So all of those higher functions. There are 3 main structural components of the brain, including the cerebrum, cerebellum, and brainstem. And we will also be looking at the spinal cord, which is located within the spinal canal and is used to communicate messages between the brain and body. On the coming slides, we'll take a closer look at the breakdown of the different components of the brain and spinal cord. The first structure of the brain that we will take a look at is the cerebrum. This is the largest part of the brain. It is divided into 2 hemispheres, the right and the left hemispheres, and then it's also divided into different lobes. So we have the frontal, parietal, occipital, and temporal lobes. This area of the brain contains folds and convolutions on the surface, as you can see here. It's kind of your very traditional image of the brain. The valleys and fissures between the matter of the brain are called gyri or sulci, depending on their depth and size. The cerebrum controls all higher functions of thinking, learning, and memory. The next structure of the brain that we'll take a look at is the cerebellum. The cerebellum is located in the posterior cranial fossa above the foramen magnum, so right at the base of the skull above the neck. The cerebellum is responsible for motor coordination, posture, and balance. The cerebellum connects the brain to the brain stem. And this would be the primary location where a defect would be seen in Chiari malformation, which we'll talk about more in the coming slides. The next structure that we will take a look at is the brainstem. The brainstem contains three components, including the midbrain, pons, and medulla. It is located anterior to the cerebellum between the base of the cerebrum and the spinal cord. The brainstem regulates breathing, heart rate, pain sensitivity control, alertness, awareness, and consciousness. The final structure of the CNS that we'll take a look at is the spinal cord. There are conditions associated with Chiari malformation that do affect the spinal cord, and those will be discussed later in the presentation. The spinal cord is a continuation of the brainstem that extends from the foramen magnum at the base of the skull to the L1, L2 vertebrae. It is housed within the spinal canal and conducts impulses from the brain to the body to generate reflexes and allow us to move and function throughout the day.
Now let's review the pathophysiology of Chiari malformation. Chiari malformation is a congenital abnormality between the skull and cervical spine, which is right back here in the back of your head. And you might notice an opening between the skull and cervical canal. Sometimes these are visibly noticeable, sometimes they are not. So the cerebellar tonsils, which is in that cerebellum region back there, will travel downward into the cervical canal. There are four types of Chiari malformation. There's Chiari type 1, Chiari type 2, and type 3 and type 4. The four types have the same general pathophysiology. However, each type affects the body a little different, and each type has its own severity level where some types are more severe than others. The onset, severity, and prognosis of these types depends on what type the patient has. And there are two specific conditions known as hydromelia and serenomelia that are also associated with Chiari malformation. These two topics will be covered later on in this presentation in more detail, but just kind of an overview of these are that these conditions are associated with a deficiency of ependymal cells, is how you say it. The pronunciation is kind of difficult. Ependymal cells within and outside the spinal cord and spinal canal. The presentation of Chiari malformation's physical characteristics can be different depending on what type the patient has and what time in life that these presentations present. So Chiari malformation may present with symptoms at birth or symptoms later in life, such as in the adolescent years and sometimes younger adult years. These patients are sometimes asymptomatic, and the Chiari malformation is just found by accident, like they have a CT scan of their head or MRI for some other reason, and it's found then without any symptoms presenting. If there are symptoms, though, they may include the following of headaches, neck pain, coordination difficulty, dizziness, swallowing difficulties, and tingling in the upper and lower extremities, particularly in the hands and feet. And once again, these symptoms are more associated when the malformation is discovered in like the adolescent / teen or younger adult years. Chiari malformation can also present at birth and typically is associated with one of, or multiple, but like at least one of three, if not more, of the following conditions of meningomyelocele, encephalocele, and hydrocephalus. So the physical characteristics of these conditions may include an opening in the lower back where the sac is protruding out, which is with the meningomyelocele, and it's visible as well. And then a protruding mass at the base of the skull, which is the encephalocele. Or in the with hydrocephalus, there is a larger circumference of the head where it also may look like it's swollen just overall, or just a lot bigger than normal than the rest of the body. And symptoms associated with these can include aspiration, reflux, nystagmus, ataxia, deep tendon reflex increases, laryngeal stridor, and apnea.
In the 1890s, a German pathologist, Professor Hans Chiari, first described brain abnormalities at the junction of the skull with the spine. He categorized these in the order of severity. There's type 1, 2, 3, and 4. The term Arnold Chiari was later applied to the Chiari type 2 malformation. These malformations, along with syringomyelia and hydromyelia, are two closely associated conditions and are described below. The prevalence of a Chiari malformation is less than 1 per 1,000 cases. Most cases are asymptomatic. Chiari malformations are often accidentally detected diagnostically while investigating unrelated reasons. Now we're going to get into the different types of Chiari malformation. Again, they are type 1, 2, 3, and 4, and also syringomyelia and hydromyelia. Type 1 Chiari malformation is the malformation that occurs during fetal development. It's characterized by the downward displacement by more than 4 millimeters of the cerebellar tonsils beneath the foramen magnum into the cervical spinal canal. This displacement may block the normal pulsations of cerebral spinal fluid between the spinal canal and the intracranial space. This form of Chiari malformation may be associated with syringomyelia and hydromyelia. It is diagnosed more commonly in adolescents or adults. Type 1 Chiari malformation are anomalies of the base of the skull and spine, which are seen in 30 to 50% of patients. These include compression of the upper part of the spine into the base of the skull with resulting compression of the brainstem, bony union of the first level of the spine, which is C1, to the base of the skull. Could be partial bony union of the first and second levels, which is C1 fusion to C2 of the spine. Klippel Feil deformity, which is a congenital union or fusion of levels of the spine within the neck with possible associated maldevelopment of levels of the cervical spine. Cervical spina bifida, which is a bony defect in the posterior part of the spine, and scoliosis, which is present in 16 to 80% of hydromyelia patients, especially in children with immature spines. Many people with Chiari 1 malformation have no symptoms. However, any of the following symptoms may occur alone or in combination. Some of the symptoms are related to the development of a syrinx, which, just like syringomyelia and hydromyelia, these terms all refer to a fluid-filled cavity in the spinal cord. The different symptoms are severe headache and neck pain, an occipital headache felt at the base of the skull that is made worse by coughing, sneezing, or straining, loss of pain and temperature sensation of the upper torso and arms, as well as loss of muscle strength in both hands and arms, and this could be a result of the syrinx. Spasticity, which is the increased tightness or tone in the arms or legs, making one less flexible and possibly causing the arms and or legs to stiffen. It could also cause balance problems, drop attacks, or dizziness. Drop attacks are events that cause dropping to the ground due to muscle weakness. Sometimes symptoms are exacerbated when asked to perform a Valsalva maneuver. Other symptoms are double or blurred vision, hypersensitivity to bright lights, sleep apnea, and in children and infants, the symptoms can be subtle and nonspecific, such as hypotonia, gross motor delay, swallowing or choking, difficulties or failure to thrive, and opisthotonos, which is a spasm of the muscles causing backward arching of the head, neck, and spine. Type 2 Chiari malformation is characterized by a downward displacement of the medulla, fourth ventricle, and cerebellum into the cervical spinal canal, as well as elongation of the pons and fourth ventricle. This type occurs almost exclusively in patients with myelomeningocele, which is a congenital condition in which the spinal cord and column do not close properly during fetal development resulting in an open spinal cord defect at birth. This type of occurs. Other symptoms that can occur with this are alteration in pattern of breathing, including periods of apnea, depressed gag reflex, involuntary rapid movement or downward movement of eyes, loss of arm strength. The symptoms associated with Chiari malformation can also be caused by the problems related to myelomeningocele and hydrocephalus. Type 2 Chiari malformation is characterized by a downward displacement of the medulla, fourth ventricle, and cerebellum into the cervical spinal canal, as well as elongation of the pons and fourth ventricle. This type occurs almost exclusively in patients with myelomeningocele, which is a congenital condition in which the spinal cord and column do not close properly during fetal development, resulting in an open spinal cord defect at birth. This type of occurs. Other symptoms that can occur with this are alteration in pattern of breathing, including periods of apnea, depressed gag reflex, involuntary rapid movement or downward movement of eyes, loss of arm strength. The symptoms associated with Chiari malformation can also be caused by the problems related to myelomeningocele and hydrocephalus. Type 3 Chiari malformation includes a form of dysraphism with the portion of the cerebellum and/or brainstem pushing out through a defect in the back of the head or neck. Dysraphism is a developmental abnormality in the midline region of the back with incomplete fusion or malformation of a seam, such as in all forms of spina bifida. These malformations are very rare and are associated with a high early mortality rate or severe neurological deficits in patients that survive. If treatment is undertaken, then early operative closure of the defect is necessitated. Hydrocephalus, which is commonly present, must also be treated through shunting. Type 4 Chiari malformation is the most severe form and the rarest. The cerebellum fails to develop normally, and there may be other associated malformations of the brain and brainstem, meaning it could be a combination of the types. Most babies born with this malformation do not survive infancy. Infants with type 2, 3, or 4 Chiari malformation have more obvious signs and are often diagnosed while still in utero. The next two slides are two conditions that can be seen with all four types of Chiari malformation. The first one is hydromyelia. This is where cerebral spinal fluid forms a cavity or cyst within the spinal cord. It could also be an abnormal widening of the central canal of the spinal cord. Symptoms associated with hydromyelia are scoliosis, loss of sensitivity, especially to hot and cold, muscle weakness and spasticity, loss of bowel and bladder control, motor impairment, chronic pain, and headaches. Syringomyelia is also a cerebral spinal fluid that forms a cavity or cyst within the spinal cord. Chiari malformation is the leading cause of syringomyelia. It is thought to be related to the interference of normal cerebral spinal fluid pulsations caused by the cerebellar tissue obstructing flow at the foramen magnum. This condition can also occur as a complication of trauma, meningitis, tumor, arachnoiditis, or a tethered spinal cord. The picture to the left does show an example of what a fluid-filled cyst looks like.
There is no way to prevent Chiari malformation. Prevention strategies include preventing symptoms of the condition, most commonly the occipital headache. This includes avoiding straining or activities that can cause strain or pain to the head or neck. Managing pathological pain remains a challenge because available therapeutics have limited efficacy and often cause adverse effects. While opioid analgesics are commonly used to treat or manage a number of clinical pain conditions, their use is limited due to side effects such as reduced GI motility, nausea, vomiting, and dependence. New interventional and peripheral regional techniques are in development to specifically target the pain demonstrated by different neurosurgical patient populations, including those with Chiari malformations. To minimize patients' exposure to the risk of opioid use, physicians have established and implemented the use of multimodal analgesics. This refers to a regimen in which 2 or more medications from different classes are used to achieve pain relief. This technique may reduce patients' reliance on opioids. Presently, common non-opioid pharmacological agents for pain medication include anticonvulsants such as gabapentin, corticosteroids such as dexamethasone, NSAIDs, anti-inflammatory drugs, NMDA receptor antagonists such as methadone and ketamine, local anesthetics such as lidocaine, nerve blocks, scalp blocks, and neuromuscular blocks such as Botox. While medication may improve headache symptoms, if symptoms include unstable gait or other neurological deficits, there will unlikely be improvement and surgery is likely needed. The main treatment for Chiari malformation type 1 is surgical, with the goal of reestablishing blocked CSF flow and relieving pressure on the cerebellum and brain by decompressing the posterior fossa. Surgery is recommended for persistently symptomatic patients with confirmed tonsillar herniation by MRI. Better surgical results are seen when surgery is performed within 2 years of symptom onset. The posterior fossa decompression is performed via suboccipital craniectomy and provides more space for the brain and therefore relieves pressure. The dura may or may not be open during the surgery as well. If a duroplasty is performed, this is done by opening the dura and placing a patch that is sewn in to help enlarge the brain covering and provide more room for the brain. This patch often is artificial material. This is a similar concept to letting out the waistband on a pair of pants. Laminectomy is an additional surgical option that can be performed in conjunction with the decompression surgery. This is the removal of the curved bony structure of the C1 and/or C2 vertebrae. This allows for even more room to be made for the cerebellar tonsils. Along with this surgery, a cervical fusion is often done as well to provide stabilization. In the setting of a syrinx and/or hydrocephalus, a shunt can be placed if decompression alone is not effective. Cerebellar tonsil cautery has been used in the past, although more rarely today. This procedure utilizes electrocauterization to shrink the cerebellar tonsils. The surgical management for Chiari type 2 remains the same. With that being said, Chiari type 2 typically involves a myelomeningeal seal, so it is usually known before or at birth. The correction of this myelomeningeal seal is generally corrected first within the first 48 hours of life. Most patients will then need a shunt for CSF diversion for hydrocephalus. Then, if still needed, the posterior decompression is performed to create more suboccipital expansion. Chiari type 3 and 4 are very serious and much more rare. In these types of Chiari, the brain matter is pushed out of the skull into a sac called an encephalocele. This also is in common occurrence with other birth defects, so surgery is performed to address those concerns first before doing traditional Chiari malformation surgical techniques. Self-management for Chiari is again limited to
We really appreciate you joining us for this presentation. If you have any questions regarding our presentation, please do not hesitate to reach out. All of our contact information is listed here on this slide. Thank you so much.